Good afternoon all. So I, Dr. Kanaram Jha, on behalf of Paediatrics Unit 3, I welcome you all for this CGR. So today we are doing CGR on primary ciliary dyskinesia. This is the very underdiagnosed conditions as like the cystic fibrosis previously. Now this is the primary dyskinesia is underdiagnosed in India. So may I request Dr. Rakesh sir to start the CGR.
Thank you, Dr. Kamal. So, good afternoon, everybody. So today we will be talking about our experience with the diagnosis and management of primary ciliary dyskinesias and how it's evolved over the last about 5-6 years to try and establish a diagnostic facility. Apart from previously we were just suspecting, but now we have done a few things, including the nasal nitric oxide high-speed video microscopy. We have had great effort put in by the electron microscopy team. Details about the genetics, and then talking about the diagnosis overall, our experience as well as the treatment outcomes, followed by summarization by Professor Carter. So, ciliary dyskinesias, I think typically we would have associated with the motile cilia syndrome, which was what previously it was known as, and most of us would have been aware about cartilaginous syndrome, a classical feature which is not seen in all patients who actually have ciliary dyskinesias. And essentially it leads to impaired mucociliary clearance because of abnormality of the ciliary beating, and which is maybe associated with a defect which can be identified in the structure, but overall it's more about the functional component where there may be a structural correlate. This figure shows us the classical configuration, 9+2 configuration of the motile cilia, and these are highly complex microtubules of alpha and beta monomers of tubulin and associated accessory elements. So as we can see, either we could look at the structure, but then structure abnormality is not what always would qualify as ciliary dyskinesia, and the other component is if some way we could look at the function or the ciliary beating and kind of try and objectively identify an abnormality. So overall, it's an uncommon condition. The estimated incidence ranges from 1 in 10,000 to 1 in 40,000 individuals. Again, because this is a condition not routinely diagnosed, or diagnostic facilities not been there in the country, we wouldn't have specific estimates for the country. However, even in the West or where there are resources, it's often an underestimate due to frequent misdiagnosis. Even there would be a limited access to diagnostic facilities. And again, there's a fair bit of overlap because most of these would come with recurrent respiratory infections, or that may be, there may be other conditions which would be there. The triad of situs inversus, chronic sinusitis, and bronchiectasis was what was identified as cartilaginous syndrome. And again, it may not be there in all. And situs inversus could exist on its own. So, of all children who have situs inversus, only about a fourth may have a diagnosis of ciliary dyskinesias. Because it's not, there are no specific features as such. If you look at it, it's often underdiagnosed, and there's a delay in diagnosis. And again, this is a report about more than a decade back, and I think some of it would be applicable to us, or maybe, the number may be more, that 70% of patients had seen a physician more than 50 times before a diagnosis was made. So these children would get repeatedly ill and would consult, but then somebody is not really thinking about the reason why there may be these recurrent infections. And again, this again more than a decade back, the European survey showed a median age of diagnosis at 5.3 years. And again, this was lower in those who had situs inversus, where the index of suspicion would be higher. Again, if you just try and look at whatever the overall condition is in terms of let's say the publications, so overall not too many publications that we can see from the country, and most of these are limited to case reports. Specific gene mutations or novel gene mutations which would have been reported rather than any large series. Even in our setting, we have kind of published earlier on non-cystic fibrosis bronchiectasis, because if you look at cystic fibrosis related bronchiectasis, that's entirely different entity. And here in about 15% of our series of 80 patients, we suspected PCD. We didn't make a definitive diagnosis because of lack of specific diagnostic facilities. And even when we talk about persistent and recurrent pneumonia, ciliary dyskinesias we have suspected, and we have given the attributed the condition to ciliary dyskinesias. Now, over the last, I think the story began about 6-7 years back when we said that it seems to be there, but we are not diagnosing. And one of the things that came up was whether you could do high-speed video microscopy on a sample that's been taken without culturing. So you could take nasal epithelial cells, that's the closest that you can get ciliated epithelial cells. And over a period of time, we explored different possibilities, including looking at an advanced instrumentation facility at JNU. We tried to look at that, and finally we kind of tried to have our own setup, which was a crude setup, which basically had an inverted microscope and a high-speed video camera, which we kind of arranged with some of our resources before we actually set up a full-fledged service to diagnose these conditions. And the initial results were encouraging. At least you could see the ciliary beak. You could at least identify that whether it's immotile cilia or not. And over a period of time, we learned as to what appears to be normal or what is abnormal. And then using a more sophisticated camera, a higher speed camera, as well as certain software, which we're going to talk about, is what we were kind of looking at. We started diagnosing. We'll share our experience, which also was one of the projects of our AIIMS Center for Advanced Research in Childhood Respiratory Diseases, which is currently ongoing. And amongst the other chronic diseases like CF, interstitial lung diseases, immune deficiency disorders, we have set up a service for diagnosis of primary ciliary dyskinesias in children. And over next 40-45 minutes, we'll share our experience as well as supplement with what the current state of knowledge is there. So with this, I'll call upon Dr. Sheetal, our TM Pediatric Pulmonology Intensive Care Fellow, to tell us about the clinical features.
Thank you, sir. So now I'll be discussing the clinical features of primary ciliary dyskinesia. So PCD affects the entire respiratory tract, right from the upper respiratory tract, the nose, the sinuses, the ears, as well as the lower respiratory tract. Patients can present right from the neonatal period up to adulthood. However, most of the symptoms begin generally soon after birth or early childhood. But the condition is often labeled as recurrent pneumonia, persistent pneumonia, or asthma, and is being misdiagnosed or underdiagnosed. So the typical clinical features in newborn, they can present as transient tachypnea of newborn, which is the respiratory distress in a full-term baby without any obvious cause, which starts generally within 12 to 24 hours after birth and resolves in 4 to 5 days. Therefore, diagnosis at this time point is difficult unless and until there is situs inversus and someone suspects it. In children, they present as persistent round-the-year wet cough starting early in life, that is less than 6 months of age. Along with this, they can have perennial and unabating nasal symptoms, which again start early in life, that is less than 6 months of age, and this may be associated with or without sinusitis. There can also be history of recurrent otitis media or glue ear with or without conductive hearing loss. Patients can be diagnosed if they have situs inversus on X-ray chest. There can be dextrocardia or heterotaxy, which is seen in around 40 to 50% of patients of PCD. In adults, they can present as unexplained bronchiectasis, but the symptoms are usually of childhood onset. Adult males can also present as infertility with or without bronchiectasis and nasal symptoms. Females can be subfertile with ectopic pregnancy and respiratory symptoms. Now, all these symptoms, if are associated with situs inversus or dextrocardia, have very high probability of PCD. The examination findings are non-specific and include failure to thrive, clubbing. The ears can have chronic middle ear effusions, tympanic membrane perforation with tympanostomies, and cholesteatoma can be there. There can be nasal turbinate hypertrophy, chronic mucopurulent discharge, nasal polyps, and sinus tenderness. The chest examination may reveal coarse crepitations, and sometimes wheezing may also be present. The cardiovascular system may be normal, or there can be dextrocardia or pulmonary arterial hypertension, or in rare cases, congenital heart disease may also be there. Now, if we look at the radiographic abnormalities, the X-ray may show dextrocardia or situs inversus upfront. There can be peribronchial thickening, atelectasis, air trapping, causing hyperinflation of the lungs, and bronchiectasis. So on X-ray is a relatively insensitive modality to pick up bronchiectasis. CT scan are more sensitive, and here we can see that the airway is dilated more than the vessels, and there is mild bronchiectasis with peribronchial thickening in this CT scan. Whereas in the further CT scans, we can see there is overt bronchiectasis, and these findings are typically more in the middle lobe and the lower lobe. And this is the frank bronchiectasis in a advanced disease. However, all these findings again are not specific for PCD. So the reported frequency of clinical features in literature, that is books, is bronchiectasis is present in almost 75% of cases. Similarly, neonatal respiratory distress, chronic sinusitis, otitis media, and male infertility have been found in more than 75% of cases, whereas nasal polyposis and congenital heart disease were reported in 10 to 30% cases. Lateral defects, as we saw, was present in 40 to 75% of cases. Now here at AIIMS, we studied 213 patients with chronic wet cough, of which we found that 45, that is 21 patients were of confirmed PCD based on various tests, which we'll be discussing later on, and probable were 39 or 18%. So a composite diagnosis of PCD was made in around 40% of cases at our center. Now, if we compare the clinical features of our patients with the international data, we can see that the age of diagnosis at our center was around 10 years, whereas in Europe and America, it is around 4.8 to 6.8 years, depending upon the geographical location. Whereas in the Japanese cohort, it was again 9.6 years, similar to our age group. The age of onset of symptoms is quite early, that is below 6 months in our age cohort also, and in the European cohort also. A wet cough is present in most of the patients. Persistent rhinitis is also seen, like in our cohort we saw it in 75%, in the European cohort it is 89%, however in Japanese cohort it was only 15%. Neonatal respiratory distress was seen in 53% of patients in our cohort. It is around 70% in Europe, and similarly 65-66% in Japan. Situs inversus abnormalities, like we said, it was in 40 to 50% in the literature. We found it in 42%. In the European cohort also it is around 44%, whereas in the Japanese cohort they found it in only 25% of the cases. Now, ear problems, as reported in the literature, is more than 75%, but we found it only in 29%. In Europe, it is around 75%. And in the Japanese cohort, what they observed was the symptoms was present only in 8%. However, on examination, more than 50% of the children had tympanic membrane retractions, suggestive of some ongoing disease. So, as I said, X-ray chest is less sensitive. In our cohort, we found that that is 40% of the children had bronchiectasis on X-ray chest, whereas on CT chest, the bronchiectasis was found in 72% of the patients. The spirometry showed restrictive pattern in most of the patients who were able to perform it. So after this, I invite Dr. Akshita to discuss about the diagnosis of primary ciliary dyskinesia.
Thank you. So, as we know that there is no gold standard test that can diagnose PCD, and the diagnosis is usually made by a composite reference standard using some clinical features and nasal nitric oxide, high-speed video microscopy, electron microscopy of the ciliary epithelium, and genetics. So, the four cardinal features of PCD that are seen are, one is, these are four features that we'll discuss. First is unexplained neonatal respiratory distress. Second is early onset year-round wet cough. Then the next is early onset year-round nasal congestion and laterality defects. Along with that, there may be the presence of multiple ear infections in the first 2 years of life with sequelae. So we can see that here with in patients who had four clinical features, there was 21% sensitivity and 99% specificity for the presence of primary ciliary dyskinesia. So derived from this, we have the PICADA or the primary ciliary dyskinesia rule. So the entry criteria for carrying on with the rest of the scoring is the presence of daily wet cough that started in early childhood. So if that is present, then only we go on with the rest of the scoring, otherwise we stop. So if the patient is born full term or has experienced chest symptoms in the neonatal period and has had a NICU admission, an admission to a neonatal unit, we give the scoring of 2 each for these features. The presence of a situs abnormality will give a score of 4, and if the patient has congenital heart defect, again a score of 2. Perineal rhinitis and ear symptoms carry a score of 1 each. So a total score of 5 or more is 90% sensitive and 75% specific for the diagnosis of PCD. At AIIMS, the mean Picador score for all the screened patients, that is the 141 patients, was 5.2. And in the patients who were diagnosed to have PCD, it was 6.8. In the ones who were not found to have PCD eventually after later testing, the score was around 3. So it's around 68 as per our data. The diagnostic accuracy of the Picador score 5 or above is 68.7% and the specificity is 89%. It carries a 90% positive predictive value and a 66.7% negative predictive value. Moving on to nasal nitric oxide, which is basically a gas produced throughout the respiratory epithelium, but the normal concentration in the nasal passages is 10 to 100 times higher than the lower airways. But this gas has been found to be consistently low in patients with PCD because of various reasons like sinus cavity hypoplasia and increased breakdown and consumption of nasal nitric oxide by bacteria, along with decreased production per se, entrapment in the obstructed airways, and decreased expression of inducible nasal oxide NO synthetase. So it can be measured by 2 techniques. One is the chemiluminescence analyzer, which employs either the breath hold method or the constant insufflation into a resistor method, or what we have here at AIIMS, the portable electromechanical analyzer. So this measures the nasal NO in parts per billion. Here's a brief video showing the process. So the nasal cannula is put into one nostril and the child is asked to close the other nostril and take breathing from the mouth for 2 minutes. During this time, the laptop would calculate the nasal NO in 90 seconds and the value would be displayed on the screen. So the value that we get on the screen, as we saw, was in parts per billion. Now we need to convert that into nanoliters per minute. So that has to be, so the parts per billion value has to be multiplied by the flow rate in liters per minute. So the multiplication factor, so there are 2 flows here, the 2 values of flow. One is 5 mL per second, which we typically employ for older children, and 2 mL per second, which we use for younger children. So the that would translate to the 5 mL per second value would translate to 0.3 liters per minute, and the 2 mL per second value would translate to 0.12 liters per minute. So for example, if the screen displays a value of 100 parts per billion, on the 5 mL per second reading, it would be 10 into 100 into 0.3, that would give us a value of 30 nanoliters per minute. So as per various studies, we can see that the nasal NO concentration of less than 77 nanoliters per minute by the chemiluminescence analyzer is 98% sensitive and more than 99% specific for the diagnosis of PCD, and the cutoff for the portable electrochemical analyzer that we use here is between 30 to 40 nanoliters per minute. A value less than that would be suggestive of PCD, and it carries a sensitivity and specificity of about 95%. In our cohort, we found that the median value was 8.4 in all our screened individuals. In those who were found to be positive for PCD, the value was found to be 5.8. And in the ones who did not have PCD on eventual evaluation, the value was 15.6. And this, the differences were statistically significant. And in the confirmed cases, taking the confirmed cases as reference standard, the nasal NO carried a sensitivity of 85.7% and a specificity of 35.4%. Moving on to the next investigation, the high-speed video microscopy, which is nothing but the ex vivo assessment of the ciliary activity of the respiratory epithelium. And we basically look at two things. One is the waveform analysis or the ciliary beat pattern analysis, and secondarily, a measurement of the ciliary beat frequency, the normal ciliary beat frequency being 8 to 14 Hertz. So we can exclude a diagnosis of PCD if both the waveform and if both the pattern and the frequency are within normal limits. And abnormalities of the ciliary beat pattern include static, slow rotating, hyperfrequent cilia with an incomplete beat. And abnormal functional pattern is often linked with specific TEM and genetic defects. So HSVM at AIIMS has evolved. Like Sir was telling us, it started from their experience. Them observing it at a university outside AIIMS, and then initially when they started, the initial sampling tool was this was an air curate, and as we can see it could cause pain and bleeding. Later on, the bronchoscope cytology brush was used, and presently we are using the cervical cytology brush here, the one below, and an inverted microscope was arranged along with a high-speed camera and software to record the video, and the procedure has improved over the years. So this is the equipment that we require for HSVM testing. This is the vial containing the RPMI media. This is the inverted microscope. This here, the attachment on the top of the microscope is the high-speed camera. Then that is the glass slide with the well, which we use to take this place the sample under the microscope, and that is the cytology brush. Here's a brief video. So initially the nostrils have to be cleaned of all secretions using an isotonic nasal spray, and then the child is asked to clean the nostril thoroughly. Once the nasal mucosa is clean, we take the cyto brush, we dip that in the vial containing the RPMI media, and then the sample is taken gently from the lateral and inferior nasal walls, taking care not to touch the septum because that would bleed. Then this is the slide with the well. Using a pipette, we place a drop onto the well portion of the slide and place that under the microscope. And then here we can see these are those were two cells showing motile cilia. So here also the department has employed some innovation using a regular mobile phone, a smartphone. Ideally, we can use any model with a high frame rate video recording or a slow mode. The video is made in slow-mo because normally the beat frequency is very high. If we have to count it manually, we need to slow it down to at least to either the slow-mo settings of the device, or when we do it in the software, we slow it down to 1/8 when we're trying to analyze. So, and this is done at 1080 pixels and at 240 frames per second. The video is then played at 1/8 the speed to count the beat frequency and assess the ciliary movement pattern. So here we can see using this stand, we can fix the mobile device onto the microscope and we can record the video directly in the device. So then not all samples are good quality samples for reporting. So this is an ideal sample. Here we can see the individual cells along with a clean edge. This is a clean edge along with cilia projecting from the surface. Here we can see that there are some minor projections that they are projecting above the, they're not in a straight line, there is some projection. Here this is a major projection, that the projection is reaching up to half the height of the next cell. And here we see even though the edge is okay, but there is only a single ciliated cell on that edge. So this is also not adequate for evaluation. And this is a single isolated cell. We should not report our findings based on the evaluation of a single isolated cells, because it could be a dead cell because it's detached from the epithelium, and an immotile single cell usually does not carry any significance. So some videos on the normal ciliary beat pattern. The normal ciliary beat pattern consists of a forward and recovery, brisk forward stroke followed by a recovery stroke, and there is some terminal bending.
So here we can see forward stroke and the recovery stroke, and this is a good edge. Here we can see that the cilia are not moving at all on this edge. Again, no movement on the entire edge. Here we can see that the cilia are moving in a somewhat circular fashion. So that is also dyskinesia. Here the cilia are beating, but they are beating stiffly. Like we do not see any terminal bending, and the strokes appear to be in a hurry. There is no proper forward or recovery stroke. Then how do we count the ciliary beat frequency manually? So as we can see, they move quite fast, and then in order to manually count it, we need to decrease the speed to 1/8 or 1/10 of the speed, and then we count the time for 10 beats, and then we accordingly multiply and report our findings in per second. So this is the video being played at actual speed. It's impossible to count manually. And now if it's slowed down to 1/10, we can count. And one complete forward and recovery stroke is taken as, that is counted as one. So this is the reporting format that we employ for HSVM here at AIIMS. We see if the recording was adequate. Then we also look at the background. Then we count the number of cells in the epithelium. So one edge has to have at least 5 cells in a row to call it as an adequate edge. Then we report the frame rate, which would be displayed on the screen, and then we count the ciliary beat frequency. Then we also report the ciliary beat pattern, and then we see whether dyskinesia was seen or not. And then we give the dyskinesia score. Like we divide the edge into 3 parts visually and see whether dyskinesia was seen in 1/3, 2/3, or in the entire edge, accordingly giving it a score of 1, 2, or 3. And then immotile cilia or immotile edges are also reported separately. And then eventually this is the final report that we release: the average ciliary beat frequency, the average of ciliary dyskinesia score. So a score of more than 2 would be suggestive of PCD. We add up and then we average them out. And then the immotility index and the percentage of dyskinetic edges is also reported. And then the final interpretation would be either the sample is suggestive of PCD, that is abnormally, the ciliary beat pattern is abnormal with the ciliary dyskinesia score of 2 or more. PCD is said to be unlikely if the ciliary beat pattern is normal and the dyskinesia score is less than 2. And for all patients, we try to get 3 HSVM samples at different points in time, provided that the patient was not having active rhinitis at the time of sampling. And 3 persons independently reported the HSVM, blinded by clinical details of the individual, and the diagnosis was made by matching of 2 persons' reports of the HSVM analysis, and that was considered as the final HSVM report. If all 3 or 2 samples, if only 2 were available for a specific patient, HSVM samples were suggestive of PCD, the patient was labeled to be having PCD based on HSVM. So this is the accuracy of, in these 2 tables we can see that in patients where we had all 3 HSVM samples having at least 1 adequate edge, the sensitivity, specificity, positive predictive value and negative predictive value was 100% when compared to the reference standard. And in patients with 2 HSVM samples having at least 1 adequate edge, up to 83, it was up to 83% sensitive, 100% specific, and had a 100% positive predictive value, and about a 92% negative predictive value. So this is our learning graph here at AIIMS. So these are the x-axis shows the 213 patients that we've enrolled, and we can see that initially in the proportion of patients having at least 1 adequate edge was just 44%, and now it's with time it's gone up to 75%. So for every 4 patients that we sample, 3 would have an adequate edge on HSVM. This here is the software which is fully automated, and that can be used to do our manual work of counting the ciliary beat frequency. It will report the beat frequency on its own. The system is called the
the SAVA system or the Sison-Nanon's video analysis of ciliary beat frequency, and that would obviously cut down the time required to capture and analyze data by 90%. Like you feed in the data, basically record the video, and it would immediately, by pressing a few buttons, report the ciliary beat frequency. And multiple patients can be worked up then in a shorter time. But it only gives you the ciliary beat frequency with amplitude and standard deviations, but it does not give you the ciliary beat pattern, which we need to then see manually, like we were already seeing. HSVM has its own limitations because it requires considerable center expertise and it's not available everywhere. There is a lack of qualitative normative data for interpretation of the ciliary beat patterns, and it's highly subjective. Like even in our reporting of 3 people, the agreement may not be 100%. There will be so that is why we have taken it as if 2 people's reading of the same HSVM is normal, that would be the final diagnosis. And then also it is subject to false positive or negative results because of superadded viral infections, environmental pollutants, poor sampling technique and processing. And but there is a way to bypass that to some extent by reanalysis of the ciliary beat frequency pattern and EM following culture of the epithelial cells. Like those same cells can be cultured, at least the effect of the extrinsic factors could be taken away with that. The next modality is the transmission electron microscopy, or the TEM, which detects the ultrastructure of the cilia, which is the basic abnormality in patients with PCD, and that can diagnose up to 70% of the PCD cases. The sampling is similar. The brush biopsy of the nasal turbinates or bronchial walls via bronchoscopy has to be done using the same brush, similar to HSVM, only the media differs. Here we would fix those cells in glutaraldehyde based media. Now I invite Ms. Shikha to speak about transmission electron microscopy. Thank you.
Thank you. Now I will talk about the techniques that we have standardized at AIIMS New Delhi for the diagnosis of PCD. For the general TEM, the procedure is first we fix the cells embedded into plastic resin and then ultra-sectioned it up to 70 nanometer and then viewed in the TEM. In case of PCD, basically the major task is the orientation of cilia. The cilia should be perpendicularly sectioned. For this, what we did, we fixed and dehydrated the cilia cells, then embedded into the plastic resin. If the orientation is up to this direction, it is good for the sectioning, and if the orientation is like that, it is not good for the sectioning, because we need the perpendicular section of the cilia. Then ultra section, if the cilia should be sectioned perpendicularly. If you section the cilia into this direction, you are mostly getting the elongated cilia, which is not adequate for the reporting. So these are the images which are the reportable ultrastructure changes observed in AIIMS New Delhi. You can see the first image is the normal cilia. The first image shows you the normal cilia. Other 2 images are the missing central microtubular flare along with the extracentral microtubular flare, missing IDA, missing ODA, short ODA, missing both arms, as well as the dislocation of peripheral microtubules. To achieve these results, there are certain problems that are associated with the technique that we have used. Now I will tell you about the problems that are associated. First one is the sample quantity as well as the quality. Less ciliary cells in the biopsy samples, major loss of cilia during the sample preparation, differential staining and low contrast of cilia than cells, and the masking of zone of interest on the copper grids. You can see here the copper grids. These are the sections. Some of their region which contains the zone of interest could be masked by the copper grids. Non-reportability due to random arrangement of cilia in the blocks used for ultra sectioning. for reportability of through TEM, at least we need 50 ciliary sections with complete ultrastructure, because there is heterogeneity in ciliary ultrastructures from cell to cell as well as also within the cells. During this standardization, we have addressed each and every problems to improve the diagnosis reporting. Now comes with the sample quantity as well as the quality. We worked a lot on those sample quantity as well as the quality condition. The sample quality can be improved by reduction of the contamination and mucus, followed by the cleaning of patient nose with saline at least 3 times, and the use of specially designed brush as shown you by the Dr. Akshita. Yes. And the gentle collection of nasal epithelium without blood. The sample quantity can be improved, that at least 2 brushes is used for the collection, followed by the slow circular motion to yield better number of epithelial cells, as well as the separate collection of samples for the electron microscopy. You can see here the image. The first image is sample without recommendation. You can see the sample is full of contamination, having blood also, and having less number of ciliary cells. The second image, the third image here is the sample after recommendation. You can see the sample is totally clean, free of mucus and other contamination, as well as having the high number of ciliary cells. Another standardization that we performed on the sample processing methodology, because to see, you have to see the ultrastructures. For this, you need the better preservation as well as the good contrast. For this, we have standardized a new fixative. As you can see the image first, these are the ciliary structures showing you the microtubules as well as central microtubule, but this image is not having a good contrast. This image is with the new fixative. You can see the good preservation along with the better contrast.
Is it particular area in the office?
Yes, sir. Yes, particular area. So, as I have mentioned many times during my talk, that I need the perpendicular orientation of the cilia for the imaging. And during sample preparation, we do not have control over the orientation of cilia, that how the cilia embedded into the plastic resin and then cut by ultra sections. So we made some modification during the images. We made some adjustment using alpha tilt for better visualization. It improves the result up to 20 to 30%. We can get more reportable cilia per block. You can understand this by these images. You can see the first image when the alpha tilt is at 0 degree. But when I tilt it to 10 degree, some of the structures got better. And when I tilt it to 20 degree, few of the structures you can clearly see, and the images is more better at 25 degree. Similarly, now so the conclusion is we have standardized the method for the better ciliary imaging using nasal epithelium. We have done various improvement at various stages. 20 to 30% improvement has been done during sample preparation imaging. 25 to 45% improvement done is in the better contrast of cilia, so that we can get the good images. 20 to 30% reduction in the number of elongated cells, that we are getting more and more perpendicular cilia, and up to 50% increase in the reportable cilia image due to alpha tilt adjustment. The overall improvement is, earlier we are getting one sample out of 25 samples, one reportable samples out of 25, but with improvements we are getting one reportable sample out of 5 samples.
Thank you. So we are doing this EM reporting along with Dr. Sudhir Rao from the Department of Pathology, but he is not well today. He will not come for this reporting part, so I will cover it on behalf of him. So this reporting and interpretation EM findings. So recently, this 2021, this guidelines are there. International consensus guidelines for reporting this EM, beat PCD TM criteria. For that to have the adequate sample, we need at least 50 cilia in the transfer sections, as mentioned by Sika. So these are as per guidelines, these are normal EM findings. So you can see this is the diagrammatic representation and this actual images. This is typical 9+2 patterns, 9 tubules on the periphery, double triplets, and 2 tubules in the center, along with this outer dynamo and inner dynamomes. These two are also normal images. These are tip of the cilia, where we have only the one peripheral tubules, and this is the base of the cilia where we don't have the center tubules. And these are abnormal findings that if there are present, we can say definite PCD. Usually there is outer dynamo absent. So you can see here only the inner dynamo there, outer is absent. Similarly in the image also. Here both outer and inner dynamo absent. Here the inner dynamo absent along with this disorganized arrangement of this 9+2 pattern. The other findings that indicate the PCD, if there is a clinical symptoms and other results also. These include this absent central tubules. These are disorganized marker tubules, and then more than 2 central tubules or only single central tubules. So what we are doing the reporting at AIIMS. So Dr. Subha's teams uploaded the AIM images on Drive. Then I reviewed the images and I numbered the images that are reportable in sequence by AIM numbers. And then 3 persons, myself, Dr. Kaba and Dr. Sudhir from pathology, we reported independently without the clinical details. And if matching finding of the 2 persons, we are considering the final finding of these EM findings. This is the one example. Suppose this is the EM number 91 and number of serial number 4. And for reporting, we prepared the format in Excel sheet format for reporting by consensus. And initially, we taken the 10 images and then reported randomly, and then then matched and then prepared the final protocol for reporting. So this is Excel sheet for reporting. And these are some images already shown by the Misika. We can see this is normal pattern also seen. Here you can see only outer dynamo are there, inner are absent. Here both outer and inner are absent. Here inner are there but outer are absent. There only 8+2 patterns, not the patterns. Maybe sometimes it's come out cilia also. You can see the 3 cilia in one membrane. And this sensitivity and specificity, and obviously because it is one of the oldest tests in the past, the very good sensitivity and specificity we have of this. But there are some certain limitations. One is the biopsy yield. So in literature, it's reported 6 to 90% in the very good centers. And as mentioned previously, it's very labor intensive and expensive procedures. Limited availabilities, only hardly, mainly I think we are doing only this EM for the PCD patient in India. And some mutation we have normal structures, like this DNS1 mutations. Sometimes in the reporting we found the multiple findings may be there in one patients. So sometimes very difficult to interpret the findings. And these findings may be confirmed by the second changes in structure by the infections or pollutants. And overall, we have the 30% yield at AIIMS. It was initially low, but now we are improving this reportability. Next is the genetic testing. So it is mostly autosomal recessive inheritance, but as compared to many other diseases, there are many genes that we call the PCD. So with time, there is gradually increase in the number of the genes. At present, we have the 52 genes on which mutations may cause the PCD. And specific gene mutations may have specific findings in the EM and the high-speed microscopy. So here at AIIMS, we perform this whole exome sequencing on 162 patients suspected PCD, and we have evaluated 160 genes that we can classify the genes, 4 genes that definitely have the PCD, and the rare genes and candidate genes. And these are the results of the analysis. In 67 patients, we identified 116 mutations in 40 genes. And among these 221 they are the core genes. Among these various variations of mutations, we can see around 30% are the pathogenic mutations, large numbers, and 57% are the variant of unknown significance. And among these variations, this DNS 11 has the maximum variations, 15.5%, followed by the DNS 5 and 9. And this is the LRR6 genes has the 6 mutations. But important finding here that all are the pathogenic mutations for this gene. And if we look at the frequency of the pathogenic genes in various genes, so we have the most common this DNS 5 genes at 71%, or similar to this LRR6 gene, followed by this 2-3 genes. If you see the literature, this is one very good review regarding this genetics, and they reported that this review of the many studies of the genetics, and this was the most common mutation, this DNS 5 gene, around 15 to 25%, and we have the 17.8%. As compared to these studies, we have the around 17%. This is the mutation, and all mutations in general the pathogenics. This is one study from this Puerto Rico. They are 38%, and in their study, this RSPH are the most common mutation, around 17%. We can say that its mutation may be vary country to country. Limitations of genetic testing is there with time there increased list of the genes, limited availability and the cost. Not all genes are tested in the commercially available panels. The one study that previously when the 30 genes were available, so this 30 genes panel will reveal only that is 65 to 70%. As already we have seen, we frequently encounter reports of this VUS, variant of unknown significance in the whole genome sequencing. Now regarding diagnosis, as highlighted previously also, there is no definite gold standard test to diagnose the PCD. So we have the company standard. This is one guideline from the American Thoracic Society guidelines. Here along with the clinical features, they are suggesting first perform the nasal NO, nasal antioxide. And if it is suggestive of the PCD, they can label the diagnosis PCD. If not available or cannot able to perform the nasal NO, they are suggesting the genetic test. And if there are two pathogenic mutations, we can say this is the PCD. If there are no mutations, then they are suggesting the EM, and if EM suggestive, we can diagnose the PCD. There is slight difference in this guidelines by the ERS, European Recipe Societies. Here, after the clinical features, they are suggesting both nasal NO and high-speed microscopy. In ATS guidelines, they are not mention of the high-speed microscopy. If both are suggestive, we can label the diagnosis PCD. If they are not suggestive or not adequate, they are suggesting that TM, electron microscopy, or repeating the high-speed after the culture of the cilia. If the again suggestive of TM or suggestive of this PCD on high speed, we can say PCD. Again in immunology, then they are suggesting the genetic test finally. So along with the two guidelines, the other studies are there. They use the various reference standards. For example, in one study they use these clinical features along with the hallmark EM findings or pathogenic mutations. In one study they use that they make the multidisciplinary team that included the clinicians, high-speed microscopists, TM technicians, and they made the diagnosis based on clinical features and all tests, nasal NO, high-speed, EM genetics by meeting consensus. In another study, they used these clinical features along with two of the four abnormal tests, at the TM, immunofluorescence, genetics, and nasal NO. So based on these literatures, we make the diagnosis at AIIMS. Definite PCD, if there is one or more cardinal features for as we discussed previously, along with two positive mutations, pathogenic or suggestive EM. That was the definite PCD. Probable PCDs, clinical features 2 out of the 4, and both nasal NO low and suggestive high-speed microscopy. For PCD unlikely with only 1 or 3 cardinal features, or only either both tests negative or only one is positive. In immunology, in many patients we don't have the tests that we consider in immunology. So all 213, so we have the 40% of the PCD. Out of these, 45 is confirmed, 39 probable. And now we then try to generate the suggested algorithm for the diagnosis. So we have looked for the sensitivity specificity of the various features. So if we take any one of the clinical features, there is very good sensitivity, but specificity is very poor. And if you use the Satis inverses, there is a 100% specific. So we can see if there is a along with weight curve, the Satis inverses, we can say definitely PCD. And if there are rhinitis plus neurological symptoms both, again we have very good specificity. And if there are neurological symptoms and Satis inverses, very good sensitivity and specificity. And if we add this test, those both clinical features along with the high speed, we have the again the 100% specificity or 17% sensitivity. And we add the both only one symptoms, that weight curve, and plus both high speed and low region low, we have the 95% specificity. So based on these results, we suggest these algorithms challenge the precision weight curve. We look for the Satis inverses. If it is there, we can label start with the probable PCD. If not Satis inverses, we have to look for rhinitis and neurological symptoms, and then perform the high speed microscopy. It's suggestive, we can label probable PCD. They are not suggestive, we should reasonably lower the PCD. If they are not having the rhinitis or neurological symptoms, we should perform the both high speed and NLO. Both are abnormal, we can label the probable PCD. And to label the definite PCD, either we need the electron microscopy or genetic test. So now I invite Dr. Nitin to discuss the treatment part.
So, being a newly diagnosed and newly described entity, so the treatment guidelines are again not very robust, and mostly they take hint from the treatment guideline for bronchiectasis from other causes. And as of now, there is no corrective or curative therapy for PCD. And it requires a multidisciplinary approach with a pediatric pulmonologist, ENT specialist, physiotherapist,
nutrition specialist and a counselor. So airway clearance therapies remain the mainstay to clear the chest, and which includes mucoactive agents like inhaled hypertonic saline and chest physiotherapy to clear the secretion. So this has to be done daily, at least twice. Then because there are frequent exacerbation and infection, so we have to treat the exacerbation when they are there, and also some therapies are recommended for prevention of antibiotic infections by long-term antibiotics if there is frequent exacerbation. Care of ear and sinus is needed by regular ENT follow-up, and supportive care in form of nutrition and immunization with yearly influenza, pneumococcal and the other routine vaccination. And then over time these patients, they develop complications like hemoptysis, which is addressed by bronchial artery embolization or pulmonary artery hypertension, end-stage lung disease that may require a lung transplant. Coming to antibiotics for prevention of infection, so there is no specific guidance for PCD. In the ERS 2017 non-CF bronchiectasis guidelines, they recommend macrolides if there are frequent exacerbations. But in pediatric age group, there is no clinical trials for PCD specifically. There is one adult trial where they showed that long-term azithromycin is associated with decreased rate of exacerbation. And currently we are having a trial ongoing in the unit, which is about effect of prophylactic long-term azithromycin on non-CF bronchiectasis in children. So here it's a open label trial with a sample size of 92. And in intervention we are giving azithromycin at 10 mg per kg twice weekly, and outcome is number of pulmonary exacerbations over 2-year follow-up. So as of now we have enrolled 46 patients, 23 in each azithromycin and control group, and even though it's for non-CF bronchiectasis, but large number of patients, like 65% of these patients are PCD in that trial. Follow-up should be done regularly at around 3-month intervals, so frequently if symptomatic. We monitor for signs and symptoms, anthropometry, surveillance sputum culture every 3 monthly, 3 to 6 monthly spirometry, chest X-ray as needed or once a year, and bronchoscopy and ABPA workup as on case-to-case basis. Long-term studies are lacking, even though Western literature suggests that there is significant morbidity, but it's not life-limiting. But studies from resource-limited settings, like this one study from Tunisia, where long-term follow-up 20 children, and 2 of them died during this period. And this is short-term follow-up of our patients. So the AIIMS PCD cohort with a median follow-up of 2.75 years. And there was no mortality. The surveillance culture were positive in 12.6%, with Pseudomonas colonization in 7.7%. As we can see that even at baseline, the impairment of FVC and FEV1 less than 80% were 52% and 60% in our cohort, representing that there is significant morbidity, pulmonary morbidity, even at time of diagnosis. And in limited analysis, we couldn't find any association of impaired FEV1 with age, gender, time of symptoms, or time of from onset disease to the diagnosis. So.
Thanks all the team members for presenting this our experience of developing a point of care test for diagnosis of this primary ciliary dyskinesia. As you know, PCD is one of the emerging chronic respiratory problem causing significant morbidity in affected individuals, and an early diagnosis may help in early institution of treatment in form of physiotherapy and antibiotics. As there is no, as you have know, it is very clear that there is no single diagnostic test and investigations available. Though genetic tests, EM and nasal NO are described, are expensive, not available at all centers. There is a need for inexpensive tests, and that's what we have developed this high-speed video microscopy over a period of time. From our own experience, we show that it has been documented to have a reasonable sensitivity and specificity. If sampling is adequate for early diagnosis, it may be a point of care test. High-speed video microscopy is less expensive. As you can see that the total cost of the basic equipment may be around 3 lakh rupees, in which inverted microscope and a high-speed video microscope with a high frame rate. And ongoing cost is very minimal. It is around 50 rupees per sample. But it requires a training to obtain good sample from the nasal epithelium by cytoplasm. Thank you very much. Any questions, Dr. Kanara?
This is our PhD team again. So any questions, comments? We have the 84% now. Among this 84% of this year, no mortality. So we have only the 2.6 around 2.5 years of the follow-up.
And this is the project mode. If you leave them in community, majority of them may get admitted in some other hospital and die of pneumonia. And when we are providing them specific services, like they are free to call any time, and then if you call them in the middle of the night, they may call them, मेरे को खांसी ज़्यादा होती है, मैं क्या करूँ? They call them and then admit them, give them a treatment, and that's why the mortality is less.
So is there any particular theme which is affected in Indian population, which is predominantly in the Indian population?
So I mentioned the really high. As only the problem also we also this is most common. But among the really there are 6. And we have only 6 patients. I think all over the journey. It's less important than other populations. This is what mostly this divisions are.
So it might be 50, 60.
I'll explain. Say, in the beginning, when we started, me and Dr. Rakesh were doing our own samples, going to the JNU and they get seeing it. So in the beginning, we started taking the sample. But if single person is taking the sample, then sustainability is poor. So that's why we encourage our all fellows, our research staff, train them, and that's why it came down a little bit. But now you can see that in my case, I have a less of a skill as compared to these people who are younger one, and then they have improved the yield of this.
And this result was repeated in EMR.
Yeah, it was same. Like we were interacting with them. So important thing for the residents is that how it has evolved. So it is not something like you take a sample, send it to the EM, get the report, and then decide about make a diagnosis. So it evolved over a period of time, and you can see that how much this thing labor has gone in the improvement of the sampling and report by interacting with all our team members.
How long does it take for this letter of take this sample?
Very tough. So it's a very labor intensive. After getting the assessment, so you work very hard.
And it must be expensive also. Not just using sampling.
But I would say you that I have to try up to the end that I have consumed the whole samples and get the whole section. So sometimes as you can see, a series of around 20 to 30 micron, a series, and I'm having a section of around 70 micron. So you can assume that how many sections I have to take and to have a good cilia in one section.
Sometimes we use 1,000 sections to see where it is.
Yes. But once we get a good section, then we can produce the results by doing the adjustment.
Initially, 20 samples is just not enough to write the whole without giving a single result.
Here is not really a point of fairness.
But it's only for them.
It's confirmation. You can have something as a microscope that's what could serve us. We don't have any special lab. Serves as a lab. So basically, we have connected to software. So the sampling and other things that's all would be a point of view. Patients, let's say, come from station, with this number, we can just quickly check it. This currently, this has to be done as soon as possible. We can't preserve it too long. The next phase is where we have project that's coming up is use cultures where you would have these sleeps better. Even the EN yield is going to be better because then you have your culture going further. This is something which is just walking. So these are just improvisation. The simple step of using the saline spray just to clear up increases the EA to some extent. How we sample increases the EA. Still not, but the culture itself is again challenging in these kind of patients. A lot of bacterial or colonization, infection would be there. Therefore, when we culture, we need to be again with pieces specific. Once that happens, then then it's not a point of care. But we have more transformative tests, but I guess that could be the next. It just shows how we began about 6-7 years back. We just tried out normal samples, trying out different techniques, what works, what doesn't work. The first camera that we got was from our resources we recruited from the proper camera, which is the German camera, would be costing about 3 lakh rupees. Just see that proof of principle whether this technique works or not. We went around multiple labs here, saw very high-end microscopes, so that's not what we could be using. These are simple microscopes of, as was shown out that you could use a good phone camera. Every feature seizes as the camera. You could kind of graph these notes which are available. So it could be taken down further. We haven't formally evaluated the phone camera as to how well the yield would be. But these are simple, I would say, I wouldn't maybe call it as simulation adaptations to help confirm diagnosis of a condition which we suspected. I think this has been going on for the last 20 years and we've given a label of suspected PCD development. I think we have a reasonable thought. I think the amount of effort that the teachers put in terms of trying to standardize even the kind of samples we have, get at least EM images, see what we typically saw in textbooks. There's something that has been a great
I mean, last July I was in England, just presented the images. And I think the lady was there who is pioneering big city, she was there. She thought, okay, I have not got this kind of thing, not wanting to have. She was the one she had started from law and I think some image of that.
So the idea is in one part is that as an emerging entity, that's one part. The other part is also to look at, once we kind of make an effort, we have the expertise available in the institute, and if we can try, we can certainly improvise to kind of get to a definite diagnosis. The first time we saw the ciliary motility, I think that was really exciting to see that, and you could go into your lab and have the lab team available, but really you could still try and make an effort. I think that's something that we can talk to the residents. Resources available. We make certain adaptations, so more definite. Any further questions?
So the effect is mostly on the program. So can the pathologist differentiate between antibody specific
So what is immunofluorescence? So are the
big understanding, Celia and
immunofluorescence is used to the antibodies are used. So you can see which part are absent. So it is well studied, not about sensitive.
Even when you can't see the Celia, there is some 200 nanometers. The Celia
antibody should be able to detect the
and
protein.
more thing also, these outer barrier, not maybe one protein. There are 4 to 5 proteins are involved. So you don't know which one.
So I guess the main point would be whether you're able to see this on right microscopy if you're used or not. If you're not, then
They have localized where it is from very small.
again use for
And not only that, these have heterogeneity. And then patient, same patient, 2 different cells. One may have a better cell. Better cell might be that.
I think there's the benefit both from resistance structure as well as
Any questions or any comment from residents?
it's not arbitrary cutoff. It's the machine, it's what you're setting on the machine to machine. It's not arbitrary.
It just seems to be the difference.
So the
Different
reference
standard, composite standard.
So as we are discussing, the single bond standard, as you can see this says specificity. Even that this genetics may be some diagnosis, even the EN may be diagnosis. This is a composite reference. So we see the clinical features along with this two or three this tests. Then we make the composite diagnosis.
The investigation of this was also part of the.
No,
Like if you're
whether HSPM are part of composite standard.
We are seeing both without HSM also with that. There must be different. We are making both ways. The confirmed cases are without HSM. They are based on EM or the generation. That we are in the most of the people will see the full reference. But confirmed without high level.
So you have, like you saw, the ATS and the ATS doesn't really talk about HSPM. The European Society guidelines, you have the first step as HSPM and the nasal label. Both of these are abnormal, you give a label actually. So one would just need to see for multiple reasons. It would have to be a composite diagnosis. Then you're right that typically a test and the evaluation should not be a part of your final diagnostic standard before both these analyses.
So, sir, it's a patient from patient center. What is the
Reference diagnosis. It hardly anyone reference with PCD.
Okay, so now
Unless very next area, then we will sufficient PCD. Without next one, hardly anything can be diagnosed with PCD.
So, like patients would be referred for evaluation for recurrent infections. Typically, that's what we believe. Now that people know that we are doing this, so maybe other centers, including PJ and all, once in a while they send patients specifically for high speed video microscopy and other testings. Other than that, it's generally recurrent respiratory infections that the patient.
So thank you all. And this video.